The views expressed in this podcast are my own and those of my guests. They do not represent or reflect those of UCSF Health or my professional and clinical roles there. The content is intended for informational purposes only and is not medical advice. Please consult a qualified healthcare professional for specific medical guidance. Welcome to In the Loop with Nadja Vlasiuk, the podcast that connects the novice, the nurse, and the nerd with clear insights into the world of healthcare. In today's episode, I'm joined by my friend Carlo Piscitello to discuss the AppleWatch and atrial fibrillation. Carlo is a process engineer and athlete who was in his normal state of health with no past cardiac history when he was notified by his AppleWatch that he was in atrial fibrillation. As you know, I'm an electrophysiology nurse practitioner. I specialize in cardiac arrhythmias. In my clinical practice, I encourage my patients to wear FDA-approved ECG-capable smartwatches. Wearing them for at least 12 hours a day, making sure it's comfortably snug on the wrist, and maximizing the battery life to avoid the lapse in wearability is important. This helps guide my clinical decisions with medication adjustments and expedites care without patients having to wait months for a follow-up appointment. Carlo, thank you so much for being here today and talking to us about your experience with the Apple Watch.
Well, thanks for having me.
You're very welcome. So tell me, I already know because we're friends, but tell me more about what you do.
I'm an engineer by trade, process engineer for a manufacturing company, but that's kind of boring, so we won't have to get too into that. But I mean, as far as just kind of recreationally, I do a decent amount of obstacle course events, racing, Tough Mudder, Spartan, stuff like that. Some of their larger, like 12 and 24-hour endurance events, stuff like that. I do CrossFit. I like to run. I like to learning how to ride a bike.
Yes, you are. And we've done some rides together.
We have. And just generally staying upright and moving. Try not to be too pedestrian.
Okay. Would you mind sharing how old you are?
I'm 52 years old.
Oh my gosh.
I know.
You're just right there in the middle.
I hope, yeah.
So tell us about Tough Mudder. What is that exactly?
Okay. So, or obstacle course racing in general really is just, for the most part, there's different distances, anywhere from there's 5Ks, 10Ks, 15K. And it's just basically it's a trail run, but every few miles or every half mile or so, they throw in an obstacle, right? So you're crawling under something, or you're swimming through something, or you're doing monkey bars, or in one case, you're literally throwing a spear into a target. So it's a competitive race series that they have.
So it's intense recess for adults.
Exactly. There's definitely there's a professional side to it, right? There's actual people who go out there and do it for a living. That's not me. I'm very weekend warrior-y, but they also have longer ones. They have 12-hour ones where they do 5-mile loops, and you do as many laps as you can do in 12 hours. They have, every year they have one called World's Toughest Mudder, which is a 24-hour. I've done that one a few times. That's really fun.
And you also do some podcasting for them. I do.
Yeah. There's a couple different little media, podcast things that I work with when I'm not competing. We cover the elite side of the sport.
That's cool.
Yeah. So, but yeah, it's just it's a way to get out and kind of torture yourself a little bit. But
so you definitely do a lot of stuff because you also do that along with CrossFit and running and cycling and yeah.
I try. Yes.
What's the name of your podcast?
Oh, thank you. So the OCR Report is the name of the podcast network that I'm on.
And that's when you do stuff with Jack, right?
Jack Goris, the photographer. He's so great.
It's just his birthday, wasn't it?
It was just, you're so good. Yeah. And then actually, I just recently started, one of my friends who I work at the OCR Report with, my friend Fran, who lives in the UK. We have a little kind of offshoot YouTube show called Fran and Carlo Get OCR Adjacent.
Cool.
So we do a little bit of obstacle course racing talk, and then we just babble on about other things that we feel like talking about. So
cool. Yeah. Awesome. So I am really glad that you chose to speak with us today because you're the perfect person to talk to about the Apple Watch that you're wearing right now. It looks great.
Thank you.
Do you want to share what happened with the watch?
Yeah, sure. It's funny. I'm not really an Apple person. They're not a sponsor, right? Are they? I'm not going to. I don't want to well, they're not now. Sorry. Well, I didn't mean, but it was one of those things. It's like, I had an iPhone for a while and then I was like, my running watch that I had died and I was kind of like looking for something else. And they were like, and I had heard about the Apple Watch and I was kind of like, whatever. And actually, I was a little intrigued by some of the health stuff they had on it. And I knew about the EKG thing, which I honestly, I thought it was kind of like, okay, yeah, EKG, whatever. Like,
this is extra.
Yeah, exactly. I'm like, when am I ever going to need that or whatever? I was literally just getting ready for work and the watch sent me an alert and it was just said, hey, by the way, you're an Afib. And so like, please consider consulting a medical professional. And I honestly thought it was just like, no way.
You're like, I'm totally healthy.
Yeah. And I'm just like, it must be a false alarm. I don't know. I'd never even done the EKG little thing on it. So, or the test, I guess. So I remember the first thing I did was, I think I screenshot it and sent it to you.
Yeah.
Like, what's this? And you were like, oh, hey, do another EKG really quick. And I had to learn how to do that really quick. By the way, you just hold a little button and it does it. And it came back and it was like, yeah, you're still an Afib. And you were like, I remember your exact text to me was like, you're an Afib, babes. And I was like, now what? Like, I don't even know what that means. Like, what is that? And I was like, oh, what a great time to have a friend who's an electrophysiologist. Yeah. And then I remember you recommended that I go see my doctor because at least like that day, preferably, because you wanted to make a point of getting the 12 probe EKG done while I was still an Afib.
Not a probe.
Not a probe, but what do they call it?
A 12 lead.
Thank you, 12 lead. because it only goes single lead, right?
Right.
Yeah. So I called my healthcare provider and they recommended I just go to the ER if I was capable. And I felt, that's the thing is I didn't feel anything, and I felt little like flutters over the years, just flutter. I don't know. And I was feeling literally nothing. And so I went in. I was a little surprised because there was like a line of people, of course, in the ER, including, I never forget. I thought like, oh man, I'm going to be here a while because there was like just some rough folks in front of me as far as like medically conditions. There was literally a guy. He had a bag of ice with his finger in it, and he had his hand. And I thought like, well, he's going to clearly be seen. So they were like kind of going down the road, like, hey, what are you here for? What are you here for? And I was just like, oh, I'm just an Afib, like whatever. And I gave her my card, and they came right out with a wheelchair, like, Mr. Piscitello, come with us. And I was like, whoa, front of the line. This is, what did I do? So that's when I was like, man, this might be kind of serious.
That I remember that day because I think it was like 2:00 in the afternoon. I was in the middle of clinic and I got a text and I'm like, oh, why are you texting me in the middle of clinic?
Yeah.
And then I looked and I saw the Afib and I was like, oh, hold on. Yeah, I definitely wanted you to get documentation of it. The watch is good, but it's better to see it on all 12 leads because we can look at a couple of different things on there and to document it. And just so that everyone that's listening knows, you have a certain type of insurance in California where going to the emergency room is kind of the answer as opposed to like an urgent care center or something, right?
Correct. Yeah.
Right. Okay.
Basically, I called the advice nurse and I told them what was going on. And it was like, okay, well, let's see if we can get you in like same day appointment with your GP. And they couldn't. And they were like, well, if you feel healthy enough, or if you can get someone like we recommend, we'd like to get you seen. So if you're comfortable going to the ER, please go to the ER.
Yeah.
And I was like, of course. Like, if you hadn't given me the recommendation, I might have been like, maybe I'll work tonight and I'll go tomorrow. But
then you could have went out of AFib and then we wouldn't have it documented.
I didn't even know what that meant at that point. I had no idea what that meant. And and first thing they did was the 12 lead EKG. And I was actually, I was sitting there hoping like, oh, I hope I'm still an Afib. I hope because I wanted him to capture it, right? Because like, that was the whole point. In fact, the doctor who I saw was like, hey, this is pretty cool. He's like, this is one of those instances where the smartwatch was correct.
Yeah.
And I was like, well, there you go.
It's nice to see something work for what it's intended for.
Yeah. Because I 100%, when it went off, I 100% thought like false alarm. I don't even know what that means, but it's that can't be real.
Yeah.
And it was like, oh no, it's 100% real. So yeah.
like you said before, you'd have felt palpitations or like heart fluttering, right, in the past, but nothing ever sustained and nothing that ever seemed concerning to you.
Right.
So what happened after you got the 12 lead? Do you want to take us down like your plan of care?
To me, it was kind of cool because I have a history of heart disease in my family anyway. I know that's not necessarily electrophysiology related. You know,
that's part of your heart, though. We have electricity, we have plumbing.
Right. It's more of a plumbing issue, right? Like the guys in my family tend to have plumbing issues there with the heart.
Okay.
So I've always been kind of cognizant, and I do like every 6 months, I'll do my
regular
lipid
follow-up
panel and all that kind of stuff and whatever. But also in some cases with, you know, depending on your healthcare provider, like you can't just go in and go, hey, by the way, I'd love to have a cardiac MRI.
Right.
They'll be like, yeah, well, so would a lot of people, but you know, no, it's kind of sad in a way. But because of this, it opened the door for me to get a lot of tests that I probably wouldn't have been eligible for yet.
When you were at the ER and they got the EKG and the doc was like,
that was a weird, yeah. I mean, it's the ER, so it took a while. Once they realized like I wasn't going anywhere, I was like, okay, he's fine. He's not gonna drop on us.
I forget. Was your heart going fast? Were you tachycardic? Do you remember what your heart rate was?
I don't.
Okay.
I don't remember. I don't remember them saying that to me.
So textbook tachycardia is any heart rate above 100 beats per minute. And then normal rhythm textbook is 60 to 100 beats per minute. And then bradycardia is anything less than 60 beats per minute. So I'm just wondering, when you were in the ER.
You mean like resting or just at any time?
At any time. Those are just like
terms?
Yeah.
Okay, cool.
To delineate slow, normal, and fast. Okay. And it's normal to have slower heart rates when you're sleeping or resting.
Sure.
And it's normal to have faster heart rates when you're getting up, getting excited or things like that. So, but if you're in AFib, sometimes you can get tachycardic or have a faster heart rate, and that's a little bit more concerning. So do you remember?
Yeah, I don't think I was.
Okay.
That didn't, at least that wasn't something that was brought to my attention that I was.
And I don't remember, I think I would have been a lot more concerned if you were a tachycardic. I would have been like, no, you need to go right now.
And I definitely didn't feel, like I said, I didn't feel anything. Like,
good.
I didn't even know. And what's interesting, I don't want to jump ahead too far, but like I had been, and I think I messaged you about it. It was like maybe a month or two later where I felt a little something and I checked and it said I was in AFib. Do you remember that?
No.
Oh yeah. And
no, because I would have, I don't know. I would have investigated that a little bit more, I think.
Oh, okay. Yeah. But I remember going like, oh, at least I felt it this time. Because I felt something was a little weird. And like, oh, maybe I'll just check. And it was like, yeah, you're not in sinus rhythm or whatever.
Did it just say could be AFib or undetermined rhythm or?
No, it said AFib.
Oh, did it?
Yeah.
And okay.
But I had that, at that point I had the, I forget the medication that I have. And the cardiologist was basically like, yeah.
Metoprolol?
Yeah, there it is. He said, if you ever feel like, if you're ever in AFib, just take that. And I was like, cool. That's it.
Wait. I need to go back because I'm confused. So you had AFib before the first time you sent me the?
No. This is.
Oh, you had AFib again. Okay.
This was a second.
I was confused. Yeah.
Yep. Sorry about that.
No, it's all right. Yeah. So, but you did feel at that time.
Yes. That's what I was trying to get at, is that there was another point where I felt something and I did another EKG on my watch and it said I was in AFib.
And you're like, now I know this feeling because it was we identified by the watch and now I recognized it.
I was bummed that it was happening again because I was like, why is it happening again?
Okay.
We've already addressed this. Stop doing that.
Oh, it's supposed to go away. But I hate to tell you this. I'm so sorry. You don't get rid of atrial fibrillation. I mean, there's no cure. You just have it.
So that's okay. Yeah. That's what I'm learning, right? That's what I'm beginning to understand.
But we manage it well. That's what we're doing right now. Yeah.
So getting back to the ER, right?
Yes.
So, which was kind of an interesting whole ordeal because, it wasn't an ordeal, but there was a lot of waiting. And then it was like, they started me on a bag and they were waiting for the cardiologist.
So they were giving you fluids.
Yep.
Okay.
And because I feel like they kept asking me like, well, they were saying, okay, one of the things we can do, you know, if it's an issue or a recurring issue, is we can do the cardiac ablation, right? And I was like, oh, okay.
Oh wow, they didn't even like tell you, hey, this is what AFib is. We're just gonna ablate you.
Yeah, and I was kind of like, oh, and they're like, what do you think? Is that something that you would want to do? I mean, there wasn't a whole lot. Honestly, there wasn't a whole lot of explanation. I was kind of like, do I need to? Like, is it? And they were like, well, no, not yet.
You're like,
right?
I need to consult my
honestly,
personal electrophysiologist. Seriously,
I was kind of like, and I totally name dropped. I was like, not name drop, but I was like, I have a very good friend who's an electrophysiologist, and I've been chatting with her about this, and she's the one that recommended I come in and get the 12 lead. You know, I was like, with the 2 bits of knowledge that I had, I was like, do you know who my friend is? She works for. And then like the next person who came up was kind of like, okay, so we hear that you're like refusing the cardiac ablation. I'm like, well, not refusing. I just said like, no.
Well, wait, were they talking about cardioversion or were they talking about cardiac ablation?
Tell me what cardioversion is.
So actually, I'm disappointed that when you were in the ER that they gave you fluids and then talked to you about a procedure, but didn't clarify what that procedure was or even explain it to you.
Yeah.
And I wasn't there, and you might have been dealing with a lot because this is all new to you, right?
Yeah, for sure. For sure.
And so what I'm thinking that they offered you was something called a cardioversion, which is where they shock your heart back into normal rhythm. They'll put you to sleep real quick and then shock you back to normal rhythm. And then you'd go home and you'd get out of Afib that way. That's one of the ways. Or we can do it with medicine. So the catheter ablation is a little bit different. You would actually meet with an electrophysiologist first, and they would talk to you about the risks of the procedure, because that's a bigger one where we go in through the groin. Well, it's not really the groin. It's where the leg meets the torso. We access a really big vein right there and thread catheters into your heart. And then they do what is called an electrophysiology study, where they map the electricity. They see where the AFib is coming from and if there's any other arrhythmias. And then right now, the energy that most everyone is using is radio frequency energy to ablate those spots. And it's just putting that energy in very precise spots in the heart, kind of burns them to stop that electrical connection.
Oh, okay.
Yeah. So I think that takes a little bit more preparation.
Clearly, yeah.
We like, where I work, we like to have some imaging done first. So we send you for a CT or an MRI first just to see, because normally where atrial fibrillation comes from is around where the pulmonary veins are in the left atrium. And so some patients, usually have 4, 2 on the right and 2 on the left, but some have 3 on the right and 1 on the left. And so we we like to get imaging before that.
And so then basically the way it ended up was clearly the cardiologist had a lot going on, and it was like, if he doesn't need the ablation or doesn't want the ablation, then everything else that we want, that we can like research, can be done like offline, meaning not today. So they were like, okay, you're free to go. And that was like at 7 p.m. or something. So I was there for like 4 hours.
Well, what did they give you? Did they give you medicine? Like, did they prescribe medicine?
Yeah, I did the Metoprolol, right? Metoprolol, yeah. And then by like that, I think they gave me some right then in the ER. And I think I messaged you because by like 8 o'clock, I was back in sinus rhythm.
Yes. Good.
Which I didn't know what that was. But now I know, and I'm like,
oh, let's talk about sinus rhythm real quick, because it's a weird thing. Because
is it?
It's a great thing. You want to be in sinus rhythm, but when you say sinus rhythm, people think sinuses are like nose sinuses.
Yeah.
Not like,
I never thought of that. Yeah, I guess so.
I've had patients be like, no, nothing's wrong with my sinuses, and I'm like, no.
I'm breathing just fine.
Yes.
Clearly.
So what that means is you have a sinus node in your heart. It's called the sinoatrial node, and that's your heart's natural pacemaker. It lives in the top right atrium, and it's shaped like a banana. So that's kind of cool. It's your heart's natural pacemaker. So when we talk about you having a normal rhythm, it's called normal sinus rhythm because it comes from that sinus node. So that's what they mean when they say sinus rhythm.
And that's what I was. But I remember, I think I talked to you that night because I was a little concerned because I'm like, well, now what? Why is it happening? So I got a series of tests done over the next couple of weeks. I had a echocardiogram done. I had a cardiac MRI, which was kind of fun. MRIs are kind of cool. I've had a few, but it's just kind of very relaxing to be in there and kind of zone out while it's ticking away. But
you're one of the few people that feels that way.
Yeah. Well, the reason that the cardiac MRI came about was because on the echocardiogram, I'll talk about this. They thought I had an enlarged aorta, which I was like, whoa, that's not good. Because I think you had I had an uncle who had an aortic aneurysm, and I was like, oh, that's not good.
Which an aortic aneurysm is an outpouching of the aorta where it's weakening the wall of that artery. And those are typically caused by high blood pressure, uncontrolled high blood pressure. So
that's what John Ritter died of, by the way.
Oh, okay.
Aortic aneurysm. That's just, I don't know why I know that. I just know that. But
and a sign of a rupturing aortic aneurysm is severe and sudden back pain. So if you ever suddenly severely feel back pain, it's always good to get that evaluated.
I would not have known that. Thank you.
You're welcome. So I hope you don't ever have that, but you're being monitored. So anyway,
so,
continue.
Exactly. Anyway, so that's I think that's kind of what brought on the cardiac MRI. They did some genetic testing as well, checking for markers and stuff.
If I remember correctly, your echocardiogram also had a couple other things that were mildly concerning, which is why they sent you for the cardiac MRI too, but nothing malignant.
No,
right?
No. Yeah, but it still freaked me out because I was like, well, hold on, like what?
Because I remember being really concerned about your blood pressure, and you're like, no, my blood pressure's been fine.
It has been. So I check it, not every night, but I check it most nights.
Good.
Because you basically commanded that I get a little blood pressure machine and put it in my nightstand, which is where it is. So,
well, the reason I do that is because hypertension or high blood pressure is known as the silent killer. It doesn't give you symptoms until it is really significantly severe, like you get a headache or you get frequent nosebleeds or you just don't feel well overall. You can have high blood pressure for years and not know if you're not checking it. And what it does is it's actually damaging the microvasculature in your organs, which are the tiny little vessels. So it's destroying all of those. And over time, that starts to create organ damage. Yeah. And then it's a problem.
I'll tell you the one thing about having the blood pressure sleeve that I have, I never realized how much your blood pressure can go up just by like having a couple glasses of wine.
Oh yeah.
Because there's been a couple, like I've actually stopped checking on nights if I had a glass of wine or something before bed or what. I'm just like, oh, am I going to check tonight? Because I know what it's going to do. It's going to show that I'm like in hypertension or something. But it's amazing like how just like a glass or two like makes a dramatic difference to your blood pressure, even for short term. But
yeah.
So I'm like,
yeah.
What are you trying to tell me?
Maybe you should stop drinking.
Just drink less. Right?
Yeah. Have you noticed a trend with your heart rate when you're drinking?
What do you mean? Like,
is it higher or lower than you think?
Oh, my rate?
Yeah.
I have not noticed. I haven't paid attention.
Okay.
Sadly, because I know if I've had a drink or two, I'm just like, well, I'm just not going to test it tonight. That's a horrible way of doing it, but it's just, I go yeah. Then it'll screw up my little history trend. I'm like, well, how come you were in hypertension for like 3 nights last week? I'm like,
well,
you don't have to ask questions. So yeah,
you mean 5 nights?
Between me. No.
Oh.
Jeez.
Yeah, no, I think it's good to, especially with you, we know that your baseline has been pretty normal, that, checking it every other day or every couple days is okay. But if you start to see that trend get higher and there's not an explanation for it, like you didn't drink a whole bottle of wine that night.
Right. Yeah.
then, it's something that we want to talk about. Because are you on any other medications?
Yes. After the cardiac MRI, the doctor said, so my aorta is not normal. It's like slightly enlarged, but he's like, who knows if it's been that way for the last 2 years or the last 15 years? Like we don't know.
Right.
But now I'm in the system and I'll get tested again, I think in another year or something.
Yeah. So they're going to provide surveillance to make sure that it's not enlarging.
Exactly. But he said, just as a precaution, I'm on like a half a tablet of losartan.
Okay. Yeah.
And a baby aspirin every day.
Good.
Yeah. So that's the only thing I'm on currently.
And then you just take the metoprolol pill in pocket if you go into Afib.
Yep, exactly. Okay. Which I haven't knowingly been in Afib since that second time.
Okay, great. And your watch has not indicated it.
It hasn't, no.
Okay. How often are you wearing your watch?
I wear it just about all day, every day, except for when I sleep.
Okay, good.
I take it off at nighttime to charge it.
Yeah,
and that's about it.
That's the one thing that I have to complain about the Apple Watch is that it does need charged a lot.
Does it? I don't know. I guess, yeah.
Well, my Garmin, it can go like days without ever touching the charger.
Oh, right.
And yeah, that when I had the Apple Watch, it was every night I had to put it on. And like this, I can gather like sleep data, which is good. Which brings us to our next point. What else did you find out about this?
Yeah. It's interesting. So there's actually not my physician, but there's a physician at my CrossFit gym who works at the same healthcare provider that I go to. And I kind of pulled him aside when I had come back, when I realized it was okay to work out and everything. And I was talking to him a little bit and he was kind of like, he's like, you're so young though. He's like, you shouldn't be having AFib. And he was like, have you ever been tested? Have you ever had a sleep study done? You ever been tested for like sleep apnea? And I was like, what?
It's a good physician.
Sleep apnea? What are you talking about? I don't snore, right? or whatever. And I was like, no, but I guess I could. He goes, yeah. He goes, email your doctor and tell her that you went through AFib, because she probably knows already. It's in your record, but let her know what's going on and order up a a sleep apnea or a
sleep study.
Sleep study.
Mm-hmm.
And so I did. But it's funny, even before I did it, I was actually like reaching out to like, old girlfriends or whatever. Just like, do I snore? Like, do you remember me snoring? I don't think I snore. Like, is it ever, because I don't know. I'm asleep. I can't tell you,
Yep.
I talk to my daughter, see if she's, whatever. But yeah, I did the sleep study and moderate to severe
Obstructive sleep apnea.
Yeah. And I was like, no way. So, because the people who I know who have apnea, who have sleep apnea, right? I don't know. I just like, usually they're just, I don't know, different.
Body habitus?
Yes. Thank you. I didn't know the right way to say that.
Yeah.
But yeah. So I was kind of like, well, clearly, and just like.
Well, and you are like fit. You're doing CrossFit. You're doing all these races and you're like, why is this happening to me? How can I have this?
And even in the sleep, sitting in the room with everyone who's at the sleep study, I'm kind of like, I just, I'm like,
I don't look like these people.
Yeah. Which is a horrible thing to like think, but it's, but I'm like,
but that shows us that there isn't a typical, like, sometimes you can assume some things, but sometimes you can't. And that's important to have these, to be screened for things like this because it really does affect you. There was an article published in Heart Rhythm in September of 2023 that correlated sleep apnea to atrial fibrillation. And actually the sleep apnea can stretch out the atria of the heart, which can lead to atrial fibrillation. So, and it can worsen it. We see patients who may have some conduction problems.
What does that mean?
Electricity problems with their heart. They could either have
conduction, like
electrical conduction. Yeah. Okay. So they can have Afib that's worse. Like we'll get the patches back. Patients will wear patches for 2 weeks the whole time. And then we can see what's going on. We'll see a lot of atrial fibrillation at night during sleeping hours, or we'll see their heart slow way down during that time. And like they might need a pacemaker if there wasn't a reversible cause. Like there's not something we can do for that, or we might have to get kind of a little bit more aggressive with our atrial fibrillation treatment. But if we see that trend, like, oh, this is happening during sleep hours, they've never been evaluated for sleep apnea, we send them to our sleep medicine team, they get treatment for sleep apnea, those things go away, or they get markedly better. Like they don't need pacemaker anymore. They don't need aggressive atrial fibrillation.
Pacemaker anymore?
Right, because they aren't having that slowing because their apnea is treated. And so their heart's able to do what it needs to do. It's pretty cool.
It is. It's not the easiest transition, like to a
CPAP.
It's not. And I'm still not. I still don't probably use it as much as I should. Like I don't use it every night.
Well, you have a different sleep schedule because you work nights.
I do. Mm-hmm. Yep. But still, I mean, I do go to bed and I should be putting it on.
Yes, you should.
I mean, that's on me. I just have to get better at that because it's got an app attached to it. It's really a really cool little system. Mm-hmm. It's all Bluetooth enabled and everything. And so, but there's nights where I'll have it on, and I'll the problem is I end up taking it off in my sleep and don't realize it because I'll wake up and it'll be like on the nightstand. Like I subconsciously took it off and put it on the nightstand, and I'll be like, I think I wore it for a long time, and I'll check the app and it was like 2 hours.
Well,
so it's just an adjustment period. But I mean, I work with guys who have them and they can't sleep without them.
Yeah.
Because they have such severe apnea. Yeah. So I would have never known that those things correlate.
Yeah.
That one could create or cause the other. So.
And isn't it cool that it like all came down to you choosing this watch to wear and then that it told you that you had atrial fibrillation?
Yes. But it was also like, it was alarming in a way because I'm like, well, I'd only had the watch for, less than a year. Mm-hmm. So I'm like, has this been happening in all the years prior to having that? How long has this been going on?
Right.
Yeah. I have no idea. So that's why I got a little freaked out. I'm like, am I behind the 8 ball here? Am I like...
Not anymore.
Because people drop dead all the time, man. I don't want to be that guy.
Well, the cool news is you don't really drop dead from atrial fibrillation. So
fair.
Yeah, it's not a life-threatening arrhythmia.
And in reality, we all drop dead at some point.
Yeah.
It's just like...
That's a guarantee.
Yes, Father Time is undefeated. Yes. But I would prefer to extend that.
Yeah. Well, I think that you're in a good place for that. And I'm really glad that you have the watch on, and I'm glad it was identified now, because as we get older, those risk factors for stroke get higher. You have a very low risk for stroke. You don't really have any of the comorbidities that lead into like that stroke risk score. Cause I think we went over that. Like, you're not 65 yet.
No.
You're getting close, but I'm just kidding.
Thank you. Yes.
You are not a female.
No.
You've never been diagnosed with heart failure.
No.
You've never had a heart attack.
No.
Or,
which, by the way, at 52 and not having one, way better than most of the men.
In your family?
Oh, yeah. Oh, yeah. My father had his first at 48, and he had his quadruple bypass at 51.
Yeah.
And the uncles had him in their early 50s.
So you are definitely excelling in the health department in your family.
Now, granted, those, a lot of those guys, just diet and they all smoke.
Smoking, yeah.
Lots of smoke. That's the thing, right? As we learned later in life, maybe a few recreational things that speed up your heart. You learn a lot of stories after people pass away. People
probably shouldn't be doing cocaine.
No. But
please don't.
You know what? It was the 70s and they did what they did. I don't know.
They did what they did.
But I like to think that, okay, I'm doing myself a service here by, I've never smoked. Just growing up in a smoking household, it was so gross.
So gross.
Right?
Same. So, I grew up in a smoking household as well.
So I'm just like, it's not my thing. Caffeine's the worst thing that I do, really.
And actually, there are studies about caffeine with atrial fibrillation. A couple from UCSF regarding coffee is that they found that the patients who actually drank more coffee had less Afib. But we know that if caffeine is a trigger for you, you should avoid it. Like if you drink a cup of coffee and you feel like, whoa, I have a lot of palpitations or my heart's racing, don't do it. But there really wasn't a correlation between coffee and Afib.
Are there any correlations between that and energy drinks? As someone who works night shift and has for 30 years.
I don't have data that I am aware of on that. I'm sure there might be some out there. So I will look for you because I think that's important. I do not recommend energy drinks.
That's kind of the general consensus that I get.
Yeah.
I thought I'd ask even though I knew the answer or kind of knew the answer.
But again, I don't know why I don't recommend them. I just have that sense. And so this is a good thing for me because it's going to make me look into that and find that evidence that I need.
Okay, cool.
Okay, so no heart attack, no one's ever told you have like aortic plaque or peripheral artery disease.
Nope.
No. Okay, cool.
My cholesterol fluctuates.
Yeah, right? But you watch it.
So. I do watch it. Yeah.
And then blood pressure. Did they diagnose you with high blood pressure?
No.
Okay, so
no, it was the Losartan thing was just because
of the enlarged aorta.
Yep.
Okay. And then you've never had a stroke, mini stroke, or blood clot in your body anywhere that you know of?
No.
Okay, great. You've never been treated for diabetes?
No.
No. Okay, great. Yeah, you have you do not have a score on the stroke risk score. So,
I remember though I'm not saying though, hold on, maybe I do. And that's not what I'm saying. But I remember you freaked me out actually when we were talking.
I'm sorry.
No, it's okay. But no, it was good. It was I think it was like the good kind of fright where it was like, okay, I need to do something. Cause can you explain, you talked about if you have AFib and you continue to have it or whatever, I'm going to screw it up, but you have the blood pools in that one little area and then it turns to jelly and then it kicks out in a big glob and then it gets stuck somewhere and you have a stroke and you die.
Or you just lose your ability to speak or, things like that.
So, I don't want that either.
Yeah. So AFib, what it does is normally when your blood is pumping through your heart, the electrical signal tells the atria to squeeze. So they give a good full squeeze. And then it goes down to the ventricles and they give a good squeeze. So blood is moving throughout your body appropriately. In atrial fibrillation, instead of the electricity telling it to give a good squeeze, it's quivering. So it's think about the top two chambers of your heart kind of just shaking. And blood isn't moving properly. It's not getting that good squeeze. It's not getting kicked through the heart like it should. The ventricles are still working fine. But in that left atrium, and I do have a little short on my Instagram that kind of talks about this. In that left atrium, you have something called the left atrial appendage. And what that looks like is a little windsock off the side of the heart. It can also look like a chicken wing or a cauliflower. It's kind of funny, the different ways that they describe the morphology of it. Blood kind of can hang out in there. And because the atria aren't squeezing, it's not squeezing out of there. Okay. And so it's hanging out. And when blood doesn't move properly, it has the opportunity to clot. And then eventually, if you go back into normal rhythm and everything starts working again, it's going to get squeezed out and go to your brain and then cause a stroke. That's why this stroke risk score is really important, that we look at these things that would put you at risk for stroke, and why anticoagulation is important in atrial fibrillation, because that is one of the life-threatening things that can come from atrial fibrillation is the stroke.
Yeah, that was frightening. Well, I was just kind of freaked out. I remember just being like, I don't want this. Like, now what?
I don't want that for you either.
I just have it forever. Like, that's the hardest part. Is
right.
Like,
yeah.
What? Like, come on, man.
You're like, I want to get rid of the Afib. I don't want it.
Yeah, okay, I had it.
Give it back.
Well, yeah, I had Afib once, but, I took care of it by sleeping better, I guess. I don't know, like, wear my little mask.
Well, that is the thing, though. There are modifiable risk factors, like you treating your sleep apnea. That's modifiable.
Right.
You can do the best that you can do for that, right? The things that we can't modify are your age. I'm sorry, we cannot make you younger, and we can't change your genetics. And so you're already aware of some of those genetic things, which I think you're doing a great job of regular routine healthcare follow-ups and things like that. But the things like evaluation and treatment of sleep apnea, avoiding alcohol as much as possible, especially if you know it's a trigger for you. And UCSF also had a study on that, where just one glass of wine can trigger AFib, but it is more correlated with binge drinking. So the more alcohol you have, the more likely you are to go into atrial fibrillation. And one of the attendings that I work with actually talks about something called holiday heart, which is like around the holidays when people are drinking and eating and everything, and then you go into heart failure and AFib, and so those are definitely modifiable, you know, or at least monitor your alcohol intake. So eating a heart healthy diet, regular exercise, maintaining a healthy weight. Obesity is really a problem into all of the areas of life. So that's another modifiable risk factor that you can work on.
Is there anything from an exercise perspective that would be detrimental for someone that's had AFib?
So what I've looked at, and I haven't done a super deep dive into it, but it looks like men who are long endurance athletes tend to have more atrial fibrillation. We see a lot of cyclists, a lot of men can exercise too hard. And it seems like women, any exercise is good for them. Like they can go hard and be endurance athletes, and it doesn't seem to lead to more atrial fibrillation, but men need to kind of be a little bit mindful of that. And I know that's very vague, and I can find the evidence on that as well, because, that's important. And especially with you doing your endurance activities, I think though that exercise in general is just really good for you, unless you have some kind of thing that would preclude you. But atrial fibrillation on its own does not, unless you're in AFib and you're super tachycardic.
Right.
Which again means very fast heart rate.
Does gender play a part? Is there like higher percentage of men who get atrial fibrillation versus women?
I thought I knew, but I can't remember off the top of my head, put on the spot. I'm going to have to look that up.
Okay. That wasn't trivia. I just don't know. And it just came to me like, I wonder if there's a...
Yeah. I don't really know if it's more prevalent in men or women. I actually forget that fact. So thank you for bolstering my I was going to say, do you happen to have more men patients than women patients? I don't know. I don't really know. I don't.
Okay.
Yeah, I know the older people get, the more I see it. And like as patients near 80 years old, I'm not surprised if they have it. I'm actually more surprised if they don't have it.
I'm sitting here as a 52-year-old and you're like, well, yeah, 80-year-olds. And I'm like, wait.
Yeah, but they didn't have a watch. They may have been having atrial fibrillation that whole time and didn't know it. And so you're already ahead of the game because now you know what to watch for, and we can manage and control this.
I'm still just bummed out about the whole thing, to be honest. I don't want it.
I understand.
I'm just saying.
I know you didn't ask for it, but here it is.
Yeah, I do wonder, how long has it been around? I don't know.
Yeah.
Because I felt you felt little things, and it's like, oh, my heart's doing something funny. That's funny, and then never to the point where I'm like, oh, I can't breathe or
right.
But it's just a little fluttering. You're like, oh, that tickled.
Yeah, and the amount of monitors that I look at. Like everybody has flutters. There are extra heartbeats from the top chamber, extra heartbeats from the bottom chamber. There's little runs of tachycardia from the top chamber, little runs of tachycardia from the bottom chamber. Some people feel it a lot more than other people. Like you're largely asymptomatic, which means you don't really feel it that much. Right? There are patients who they know exactly when they go into AFib, and it makes them miserable. Like my uncle, he's been in AFib for 15, 20 years now. Just all the time. Never, they never tried to get him into normal rhythm.
How do they get the blood out of the windsock then?
He's on a blood thinner.
Okay. Because I'm like, that sounds like not at all what you want to have happening.
Yeah. Some patients, dependent on certain things that happen to them, everyone is different.
How old is he?
He is in his late 60s.
Okay.
Yeah. Yeah. So he's been in it for a long time, and he takes his blood thinner every day, and he takes a beta blocker every day, and he doesn't even know it. I mean, he knows he's taking the medicine. He doesn't know he's in AFib.
I know. I've heard the term beta blocker so many times. What is it?
What metoprolol is.
Oh, okay. Okay.
Metoprolol, atenolol, propranolol, carvedilol. Yeah, there's a lot of, all the lols. All the lols.
Got it.
So what beta blockers do is they tend to work on your heart, controlling your heart rate, and they can also lower your blood pressure. Some do that in a larger capacity than others. Metoprolol is one that we really like to use. It's a great medication, and it has very little blood pressure effect. At least from what I've seen in my patients. Like if I were to give you carvedilol, it would really drop your blood pressure. But it also has like a very small ability to kind of suppress arrhythmias or extra heartbeats. Like the premature ventricular contractions that come from the bottom chamber of the heart, we use metoprolol to suppress those. So it's a great medication. It does a lot of good things for your heart.
Okay.
So what are the next steps for you outside of treating your sleep apnea, paying attention to your alcohol intake, your blood pressure, and getting regular checkups?
I mean, for me, honestly, that's kind of the main plan of attack, really. And that, and then just staying active. That's my thing. It's just trying to keep moving, running a little bit, cycling a little bit, keep CrossFitting. I don't do quite as many events as I used to, but I still hit a couple a year. I don't do the big like 24-hour race as much as I used to, although I would still like to do that again. Hopefully one of these years. Yeah. Just stay upright and keep moving, you know?
And wear your watch.
And wear my watch. Exactly.
Yeah, because then your treatment can change over time.
Right.
You know, because there is this concept of atrial fibrillation begets atrial fibrillation. So the more AFib you have, the more AFib you have. So as soon as we know that you have it again, we get you back in a normal rhythm and keep you there. Or, you know, we start a medication or we consider an ablation or something like that.
Right. Really quick. When do we ablate? What?
So catheter ablation is actually a class 1 recommendation now in some patients by society guidelines. So it's something that we could consider right now. A lot of electrophysiologists are still a little conservative and want to see how much burden you have of atrial fibrillation and how it affects you before they consider doing a procedure, because there's always risks with everything.
Sure.
And so we have to weigh that, and, you know, we have to see where you are with that. Because if it's every time you're exercising, you're going into AFib, that's probably something we should take care of. But if you've had it twice and you haven't had it anymore, for right now, let's just wait and see, you know?
Okay.
Does that seem reasonable?
That seems reasonable.
So, Carlo, I super appreciate you coming and being the first guest on In the Loop.
Well, I'm flattered that you asked me to come on, so thank you.
I think there was the threat of our friendship if I didn't ask you to come on, but...
I mean, only because it was topical.
You're right.
It meant no harm.
No, it's perfect. I appreciate you elaborating on what the smartwatch did for you, because really, I mean, we wouldn't have known, and...
Yeah.
Who knows?
I still kind of get weird about it sometimes.
It's a great tool that may have changed your life.
Absolutely.
You know? So really
I do say that the Apple Watch saved my life. I don't know. It's a little dramatic, but occasionally I'll throw that out there.
Oh, so. We love you being dramatic. It's the best.
I'm really good at it. So,
well, I appreciate your time, and thanks for sharing with us.
Yeah, thanks for having me.
Of course. Thanks for tuning in to this episode of In the Loop with Nadia Vlasiuk. I hope you found today's discussion insightful and empowering. Feel like diving deeper into the topics presented today? Be sure to check out the show notes for references and more helpful information. You can also visit our Substack or Instagram, Facebook, and TikTok. Remember to stay curious and stay informed. Now you're in the loop.